So good evening. Welcome all of you to the 16th clinic of Advanced Gastro Summit 2020. On behalf of Gujarat State Chapter of Physicians and Surgeons, Association of Physicians of Gujarat and Ahmedabad and Family Physician Association, I welcome you all to 16th clinic on chronic diarrhea, how to differentiate between large bowel and small bowel. So today we have our faculty, Dr. Gautam Tambulia, who is a moderator, and we have Dr. Venkat Iyer from Bhavnagar and Dr. Nakul from Gandhidham, who will be chairing this session. Before that, I introduce Gautam. I would like to mention that every Wednesday we are having this clinic summit, but for next Wednesday, we will have on this Sunday. The only reason is because there is an international faculty and his time is not matching. So we will be having a lecture, video lecture on cholangiography and pancreaticoscopy on by Dr. Moon and Dr. Sanjay Rajput. So both of them will be presenting their video lecture from 12 to 1 on this Sunday, 17th. So Dr. Nakul is also with us. Welcome, Nakul. So Dr. Gautam is a very young and dynamic gastroenterologist from Ahmedabad, and he's director of Divine Gastro Hospital. So welcome, Gautam. I request you to please introduce our chairpersons, Dr. Venkat and Dr. Nakul. And Venkat bhai, you can take honor to introduce sir, and then sir can start.
So, hello everyone. I am Dr. Gautam Tambulia from Ahmedabad. First of all, I thank Dr. Yogesh Harwani sir for allowing me to moderate this session. As this session is, the speaker is our international and national faculty, Dr. and Professor Govind Makharia sir. He is from Aiims, New Delhi, and he will share his knowledge on chronic diarrhea. So for today's session, the chairperson is Dr. Venkat Iyer sir. He is a senior gastroenterologist from Bhavnagar, and Dr. Nakul Murakia, he has already joined, I think, and he is from Gandhidham, and we have started our practice together. So I ask my chairperson to please introduce to our speaker who will and start the session.
Sure. Dr. Makharia is someone we adore. He is a professor at the All India Institute of Medical Sciences, and he is also the secretary of the Indian Society of Gastroenterology. Personally, I've had very good interactions with him. He is always encouraging to young gastros, and I think he has changed the shape of how he has changed the way how ISG works. And I always see him as very approachable and a very good human being. Of course, we are going to listen to him about his knowledge on chronic diarrhea. His research interests are celiac disease and chronic diarrhea and functional bowel disease. So over to Dr. Makharia sir regarding the management of chronic diarrhea.
So very good evening everyone. Thank you Dr. Yogesh for very kind invite. Thank you Dr. Gautam, Venkat and Dr. Nakul. And chronic diarrhea is a very important clinical problem, and we'll see a lot of patients in our day-to-day practice about chronic diarrhea, either functional or organic, and this is an important clinical problem. The number of causes are numerous of chronic diarrhea. It may be from small intestine, from large intestine. So question is, how do I approach a patient who has a chronic diarrhea, and how do I select my investigations in the most appropriate manner, that I do minimal investigation but reach to the best of the possible diagnosis. And diagnosis is certainly important, finding etiology. If you know etiology, you can treat these patients very, very well. So the objective of this today's talk would be how do I approach a patient with chronic diarrhea. So stepwise clinical assessment and stepwise investigations. And they are two learning objective of today's time. So question is, how common is the chronic diarrhea in our community? And there's data from world over and data from our own country that about 10% of people in our community have chronic diarrhea. And these can be either functional or organic. This can be from small intestine, large intestine. but 11% of our people will have a chronic diarrhea. So it's important to recognize that this is not an uncommon problem. 11% of normal healthy people in our country will have a chronic diarrhea. So what is diarrhea? And this is a bit of confusion. Therefore, I thought, let me dwell upon this question, that we learn this term from early part of our life, about diarrhea. But again, as we come into reaching to a diagnosis, that's important to understand what the diarrhea is. Is it about frequency? The more frequency, is it only that? Or it is about liquidity or fluidity of stool, means the stool is more liquid or more fluid in nature, or it is volume of stool, or is it combination? So there are three important components here once you talk of diarrhea: about frequency, about liquidity of stool, and also how much is the volume. And these three things are extremely important. And let's see how with these 3 points, how do we go further? The question comes, why? What is the frequency? Why there's increase in frequency of stool? And here we'll find rectum. Rectum is the seat of frequency. Rectum drives the frequency, because as we know, as stool comes to rectum has a sensitive fibers, and if once rectum gets distended, at that point of time, this will initiate the defecation arc. The signal goes to the brain. Brain accepts, okay, one can go to washroom. Then there's efferent from the brain, and then there is a contraction of rectum, the relaxation of internal sphincter, relaxation of external sphincter, and altogether there is a passage of stool. So rectum is the organ which drives frequency of stool. So let's take this example, that here we have patient where day to day stool comes to the rectum, and this stool, rectum is there, in the stool is there, and once you want to go to washroom, then there is a three things happens, that the rectum contracts, the anal sphincter relax, and also there's a puborectus muscle also relaxes. Therefore, there's a straight tube, and then stool can pass easily, right? This is normal defecation. But sometimes what happens, that this pathway, so the anal sphincter doesn't relax, or the tube is not that straight. What happens? Some stool passes, but some stool stays back in the rectum itself. It can't pass through. There's still a lot of stool in the rectum, but can't pass because the whole tube is not straight, right? But what happened to this person? This person will have since rectum has a stool, he will have persistent desire to pass stool. Despite passing his stool, he still has sense of incomplete evacuation. Therefore, he'll try to go to washroom again. But again, there's only little amount of stool will pass. Therefore, he will have more frequency. I hope you got my point. That person will have more frequency. The stool is incompletely evacuated. The person will have more frequency. Therefore, frequency does not mean that all diarrhea will have a high frequency, or all those who have a high frequency will have a diarrhea. Please keep that in mind. So now coming to, so if you have more frequency but only have a hard stool, then this is not diarrhea. And this is a very important point I want to emphasize on. More frequency, but if the stool is hard, then this is not diarrhea, and this is because of this phenomena that's called pelvic floor dyssynergia, where the rectum is not able to evacuate the stool from rectum to outside, and therefore a person desire and have more frequency. So is it frequency? Certainly not always. So most diarrhea will have a high frequency, but high frequency does not mean that they have a diarrhea. You will realize that a lot of patient comes to us that they go to washroom time and again, and they come to मुझे diarrhea होता है, I have diarrhea. And if you ask what type of stool you pass, he says, I pass solid stool. So this is not diarrhea. So frequency, most diarrhea will have high frequency, but all those have high frequency may not be classified as diarrhea. Then come to second point, what is the liquidity of stool and fluidity of stool, and what is the volume of stool. So these 2 points also important. Let's see what happens about that. So what is the liquidity in the stool? So more liquid stool will be because of acute diarrhea, but certainly whatever region that is there, there's a large amount of secretion of liquid in the rectum. no, in the small intestine because of, say, acute infective cause, or because of malabsorption, or because of any cause which lead to a lot of secretion in GI tract. So all these are large volume. So all this large volume from a small intestine goes to large intestine. Large intestine absorbs. Large intestine absorbs, and therefore, what is left out is passes in the stool as a as passes as a stool. So anybody who has a uh, imbalance between amount of stool or amount of food content and amount of secretion versus absorption. The absorption less, there will be more stool. The absorption is proper, there will be normal stool. So this balance is important, and which decides the volume stool. Second point is the secretion. If there's more secretion in the GI tract, like acute cholera, or somebody has some neurohormonal tumor which secretes a lot of hormone in the GI tract. Therefore, there a lot of secretion occurs in the lumen that can also lead to large volume stool. And please remember that whatever amount of fluid comes from small intestine to large intestine absorbs fluid majority of time, a large amount of fluid, and therefore what is left out is goes as a stool. So we call diarrhea if there is more than 3 stools a day, or if the volume is large. And one must know this chart. And this chart is available on internet. You can download on your phone. And this chart is extremely important once you talk about diarrhea or constipation. And I believe this chart is extremely important. And this is called Bristol stool chart. And we call it the type 3 and 4 are normal stools. Or mostly type 4 is a normal stool. Have a as stool stays for longer time in the large intestine will drive or absorb water from this stool. Therefore, stool becomes more dry. Therefore, it cracks in its surface. It may, and then if you have too dry, it will break into small pieces. So type 3, type 2, type 1, they are typical stool of a constipation. Constipation, what does it mean? That stool has stayed longer in the GI tract, therefore, or in the colon. Therefore, colon has absorbed all the water from it, and they have broken into small pieces, right? So if the transit is more, or there is a problem with absorption, then stool becomes 5, 6, 7, which is like typical. This is a typical stool of malabsorption. These two, right? Where stool has more water, and they may look like a mushy stool, fluffy stool, which floats on the pan. And type 7 is typical watery stool, which you see in patients with cholera or acute diarrhea, watery stool. So these are very important. So these 5, 6, 7 are typical diarrhea. So somebody tells us, like, I pass this type of stool, but I pass 4 times a day. This is not diarrhea. This is a constipation, because stool is staying longer in the colon. But if you have this kind of stool, then this type stool is defined as diarrhea. So more frequency, more volume, and always keep in mind that most diarrhea will have this kind of consistency of the stool. Now, one more point comes, some confusion occurs. What is incontinence? And sometimes people get confused with incontinence and diarrhea. So, what incontinence is? Incontinence is involuntary passage of gas, liquid, or stool without person knowing it, and they pass in their undergarment. And incontinence to gas is quite common. And this continence is maintained by a muscle called external sphincter muscle, because external sphincter muscle is in our control. So this is under our voluntary control. So, and we contact this muscle so that the stool does not pass. So any difficulty, any problem with the external sphincter muscle because of any cause will lead to incontinence. What is incontinence? Incontinence, 2 points are important. That is involuntary. Person is not able to control it and is unconscious. Patient doesn't know it, but he passes stool in the undergarments. Whereas diarrhea is voluntary. The person has to go to washroom, and this is conscious event. So these 2 points are important to understand, and most incontinence are of small volume type. There's some patient in ICU, and you find that the person has a incontinent but large volume. Then there are two pathology. Large volume cannot be because of external sphincter. It means this person has a defect in his sphincter muscle because of a subconscious state, or because of defect in the architecture of the muscle, or it also because of volume, because there is also a disease in the small intestine or large intestine. So keep in mind, large volume stool, which is spontaneous, uh, uh, is not only incontinence, but also because of disease of small and large intestine. So what are determinants of chronic diarrhea? That if you have a malabsorption or secretion in the small intestine, and colon is not able to absorb fluid properly, that leads to converting to diarrheal stool. And also, as I said earlier, the rectum is the seat which decides the frequency. So any disease of rectum, be it inflammatory disease like ulcerative colitis, will have more frequency, or even there is no disease, but rectum is sensitive, and the term called Bristol hypersensitivity. The rectum is sensitive, therefore it perceives, and therefore it releases the sensory signal to the brain, and then you have efferent. So and this is a typical feature of IBS, that IBS in patients will have a hypersensitive rectum, therefore they have more frequency in the stool. Therefore, three things to remember: that more volume, more frequency, and frequency is decided by the rectum. So with these three important concepts, that frequency decided by rectum, volume, and type of stool. So suppose I give it just a couple of examples. Somebody at a high frequency, right, and high volume of stool, 5, 6, 7 times a day, and and large volume stool, and which is contains watery. There's a typical secretory form of diarrhea, and one should remember very special diagnosis in these patients. If it's acute, there's acute diarrhea, like infective in nature, or if it's chronic, then you must think of some disorders which secretes some kind of hormone or chemokines in the GI tract, and therefore there's a more secretion in the GI tract. If you have high frequency but volume is low, the more frequency but no volume, then this is a typical large bowel type diarrhea. And if you have a normal high frequency or normal or high volume stool, then this is typical of small intestine. I will go back, we discuss more about it in much more depth in subsequent time. So now coming to with this basic concept of the type of diarrhea, let us look at what are the causes of chronic diarrhea. As we said, chronic diarrhea can occur in the disease from the small intestine, disease of large intestine, and also disease of rectum. So in the what are the cause in the small intestine? Small intestine has three phases of absorption. The first phase is a luminal phase, that once food comes to the intestine, the secretion of enzyme from the pancreas, gallbladder, right, and that leads to luminal digestion. So any disease in the pancreas or the bile duct can lead to diarrhea. But again, these patients do not have typical diarrhea. Like chronic pancreatitis, patient will come with pain abdomen rather than with diarrhea. So this is not an important cause of chronic diarrhea. Most patients will have chronic pain, first symptom. Bile acid diarrhea has now become very important, and we will come back in subsequent discussion. But one must remember, bile acid has become an important cause of chronic diarrhea. But most important is a mucosal phase of disease. Mucosal phase means where there's absorption of partially digested food. So in the mucosa, there's a terminal digestion and then absorption. So if the disease is diffusely involving the small intestinal mucosa, then that can have a chronic diarrhea. And the cause could be celiac disease, tropical sprue, immunodeficiency of any nature, parasitic disorders, Whipple's disease, a disease of lymphoma type is called immunoproliferative small intestinal disease, not very common, autoimmune nephropathy, HIV, Crohn's disease, and all of these can lead to malabsorption, and therefore large amount of stool which patient will pass. And other type is a lymphatic block, then patient can also have a chronic diarrhea. And there's some parasites like Giardia, Strongyloides, Cryptosporidium, Cyclospora, or Isospora. As I said, this is important cause. So these parasites leads to chronic diarrhea and malabsorption. The point is important that if you look at what is the most important cause of chronic diarrhea with malabsorption in our country, then celiac disease, tropical sprue, and immunodeficiency and Crohn's disease are the four most important cause is celiac disease, tropical sprue, immunodeficiency, and Crohn's disease. I'm talking about the small intestine. Now coming to large intestine. In the large intestine, again, there are two types of disorders. What's called majority of that is functional GI disorders. It could be functional GI disorder, could be IBS, means IBS diarrhea predominant type, or it could be functional diarrhea. Or they are the most important cause of chronic diarrhea in our population. Then we have organic disorders like ulcerative colitis, Crohn's disease, and microcystic colitis. The list is too huge, but I'm not including all of them. But again, large intestine, functional disease, or organic disease. Furthermore, other cause of diarrhea is a secretory nature. Again, one must remember this. Some patient comes high frequency, high volume stool. This is secretory nature, and one must look for neurohormonal disorders. Means some disorder, some neurohormonal, some disorder which secretes hormone in the GI tract and leads to more secretion. And one must keep this in mind in always. Sometimes those who are diabetics do have a diarrhea. And the first thing to think in diabetic is the diabetic autonomic neuropathy. That's the most important cause. But do remember that drugs like metformin will lead to diarrhea. And you do anything, you do whole set of investigation, you don't find any cause, diarrhea persists. In those situations, we stop metformin and see the patient responds or not. The many number of drugs, other drug is olmesartan and its variants, that also leads to changes in the small intestine mucosa and can lead to diarrhea. One must remember bacterial overgrowth because of any region can also lead to diarrhea. And I want to make a point again here that intestinal tuberculosis, although everybody believes that TB is a cause of diarrhea, it is not so. Intestinal tuberculosis is not an important cause of diarrhea. So we see that a lot of patients are treated with chronic diarrhea with ATT. That may be avoided. Unless there is evidence for tuberculosis, unless there is a stricture, because most patients with tuberculosis will have a stricture of the small intestine, and therefore they will have most will have pain abdomen, and diarrhea is not an important feature of tuberculosis. Please do remember this point. So with that basic background, let's take a case and take the case forward. So this is a young girl who came to us. He's a 12th standard student, and he wanted to become a civil administrator, very bright girl. She came to us with symptom of chronic diarrhea, which is stool were 3 to 4 per day, and these stool were really good volume stools. She was 16 years, but she have a failure to gain weight and height. She was short height. She had abdominal discomfort, and despite being 16, she had not attained menarche till then. She also had weakness, fatigability, but no joint pain and no fever. So with this symptom, she had been seen at multiple places. She was advised antitubercular treatment at one place, but she took for 2 months and then stopped since there was no improvement. And when she came to us, she had a height which was quite less than 5th percentile, and expected about 140 to 146 centimeter. She was just 123 centimeter. So she has a really short in height. Her weight was also underweight. Her BMI just 15 BMI. She has a marked pallor. She has magenta tongue. She has dry skin. She has pedal edema. And also, despite 16 years, she has a secondary sexual characteristic of tenor stage 3. And others were normal. So she has a plethora of symptoms that she has a chronic diarrhea, she has a failure to weight gain, and same, we have all the features out here. So what all this girl had? This girl had chronic diarrhea, had anemia, had growth failure, had gonadal failure, had constitutional symptoms, and had typical malnutrition. So what all? And if you look at, how do I approach this person? So this person, do I think of small intestinal disease? Do I think of large intestinal disease? Do I think of rectal disease? And then therefore I plan my investigation. So to do that, to understand more about all these symptomatology, let's try to convert this symptom from where these symptoms are arising from. in the small intestine, large intestine, or in the rectum. So how do I systematically approach such an individual? So for here we define, there are these steps of, these are some of the steps where we look at. So we want to answer these questions to define small intestine, large intestine, or rectum. First thing, is diarrhea acute or chronic? Is this the diarrhea functional or organic? Is diarrhea small intestine or large intestine? Is diarrhea, what is the top type of volume stool? What is the continental stool? Is there associated feature of malabsorption? Does the person have pain or no pain? Does she or he has bleeding or not? Or there are any features of inflammation? So if you have answered these questions, in clinical, I'm talking about the clinical bedside points. If you ask these questions bedside, we'll have a logical knowledge about this person, and we also will like to know, we'll have some idea that from where there is a diarrhea coming from. So maybe we take a break of a couple of minutes out here if there are any question. Or
There is a change in how do we conduct all sessions. So today we had decided that as this is a very important topic and very basic topic, we will first complete the symptomatology and go through some questions by the audience. And then we will start further this case. So my request to all audience and chairpersons, if you can share your experience for what sir has till now discussed, and audience can place their questions in the chat box. So is there any importance of nocturnal diarrhea? Patient is having nocturnal diarrhea or not? Because many times patient come with high frequency, but they don't have any weight loss, no nocturnal symptoms.
I'll come back to that in a minute time. Again, if the nocturnal means it's more or less organic disease. Those people who have a functional disease, they will not be nocturnal diarrhea.
Just to share, Dr. Govind, I had a patient who was diagnosed as having celiac disease by serology as well as biopsy, duodenal biopsy. But actually, he also had a lot of functional overlap. So in fact, he was already on a gluten-free diet and he was strictly adherent to it. Follow-up titers of TTG were also okay. But because of he had a lot of anxiety and probably there was some overlap of functional bowel disease as well. So it was only after he was given some anti-anxiety then his symptoms. So how do we approach such a patient who has mixed like overlap of both functional and organic disorders?
So we treat both together. And this also point to understand. I want to make one more point which I always teach students out here, that we are taught in medicine from
It's 9 o'clock.
early part of life that try and explain everything by one disease, and common disease occurs commonly. So these both are not true in advanced practice. You're a specialist, you like to see more uncommon disorders, and also the same person can have two disorders. And I give example that if somebody is alcoholic and also is diabetic, so he has a liver disease which has both alcoholic and non-alcoholic. It's both. We can't say his liver is only because of alcohol or only because of fatty liver. So keep in mind that the same organ can have two diseases at one point of time. As I rightly said, that the IBS is so common in our population. So a person can have celiac disease, can also have IBS. And unless we recognize this, we keep treating celiac disease, but we don't recognize increased frequency because of anxiety. Therefore, symptom will never improve. Yeah, perfect right, Dr. Venkat. I mean, this is a very important point you made. So with this, we can go forward and then we come back to...
So actually, there are 2-3 questions, but they are based on treatment, so we can address them at the end.
Sure, absolutely. Yeah. So with these questions, we have 7 or 8 questions, and we should answer these questions as we see the patients in our clinical bedside. And I'm talking about only clinical bedside questions. So for the first step is defined as diarrhea are acute or chronic, and simple. Any diarrhea which lasts, most diarrhea of acute in nature will last within 2 weeks, they will recover, but chronic will be those diarrhea which are more than 4 weeks. So any diarrhea which persists for more than 4 weeks is called chronic, and they will require some amount of thinking. The second question or second step, that is the diarrhea is functional or organic, and this is important. Of all diarrhea, majority of them are functional, and only few are organic. Therefore, we need to address this question very appropriately to see that this person has a chronic or functional or organic disease. So the point, which a couple of points which are very important to understand, that somebody has an organic disease may have a weight loss, may have a more constitutional symptoms. They maybe have a more of a weight loss, fever. All those things will likely. Second would be more important that if there's a person has more of a one. This point is very important as Dr. Yogesh made a point. Nocturnal diarrhea. So those people have a diarrhea in the also during night time and to get up is mostly organic in nature. Most functional will not have nocturnal diarrhea, and this is a very important point to understand. Other point is that if there is an increased gastrocolic reflex, that after every time they eat and they have to go to washroom, this typical feature of functional GI disease. It means gastrocolic reflex is a normal phenomena. After food comes to stomach, there's a rectal contraction. But this kind of gastrocolic reflex is heightened in functional diseases. So those who have a more gastrocolic reflex, then you will think is a functional disease. So some of these points will help you deciding this is functional or organic in nature. Step 3. So this person had a typical organic disease. I'm talking about the girl who came to us, the 16 years girl who had a features of malabsorption. So this is a typical organic disease. Now coming to step 3. Now we want to know is the diarrhea occurring from the small intestine or large intestine, and there are a couple of points which help us deciding. As I said, most large intestine diarrhea may have high frequency because of rectal hypersensitivity. They may have a high frequency. Ulceritis, rectum is sensitive, therefore high frequency. But most small intestine diarrhea have a low frequency. I wrote 4 here, but 4 may not be right. But simply remember, high frequency may be large bowel, and low frequency is a small bowel type. Most important is that most large bowel type is a small in volume, whereas the volume is maybe larger or bulky stool in the small intestine type. If there is a blood or pus in the stool, it suggests there is a large bowel type. And if you look at all these features in this girl we're talking about, she had a large volume stool, which was mushy in nature. So we call this person had a small bowel type. I'm using all these steps into a given patient we talked about 5 minutes back, the 16 years girl who came to us with chronic diarrhea. Now coming to step 4, and we want to look at to know more about the stool, and this is very important that and this also help us in making a diagnosis. Let's look at volume of stool, how much volume the stool passes. If the small volume is typical small intestine type, but if it's large volume, high frequency, I said this is a secretory diarrhea. Never miss out this. There are only few patients, you'll see this patient once in a while, but this is typical characteristic. Chronic in nature means recurrent. They have a high volume, high frequency. This is secretory in nature. And you will think of a tumor which leads to secretion pneumonia. So this is most likely because of a neuroendocrine tumor. Not common, but this is very characteristic. If you have a stool is large volume, which is a frothy stool, sticky stool, it passes a lot of flatus, this suggests there is typical malabsorption. Malabsorption means small intestinal mucosal disease. So volume and content, if there are such features, they help us a lot. They may not be there in all the patients, but if they are there, you know what you're talking about. This is a NET type disorders, and this is a malabsorption. It means small intestinal mucosal disease. Step 5, that look at what the patient does. The patient have features of malabsorption. So they can have symptom if there's malabsorption, means carbohydrate, fat, and protein, or vitamins. So what symptom they can have? If there's carbohydrate malabsorption, there's no energy. There's no carbohydrate, it's not absorbed properly, so the patient will feel weak, they will be bloating, the food is not absorbed properly, therefore that lead to flatulence because of colonic fermentation, and therefore there will be more water because of unabsorbed food in the stool. There will be more warming, like gurgur in the abdomen. So all these features will suggest carbohydrate malabsorption. You've got fat, there's no body fat because the fat is not absorbed, and patient can have a steatorrhea. Steatorrhea means greasy stool. And if no protein is absorbed properly, then they will have a somatic protein loss, which means muscle mass is very poor, and visceral protein means low albumin. This patient can have edema. So these features tells you carbohydrate, fat, and protein malabsorption. And this can occur because of multiple causes, but in this context of chronic diarrhea, these are important. Then this patient had all of these. She had a typical diarrhea, and she also had a poor weight gain. So this patient had typical features of malabsorption. Now going further, look at vitamin deficiency, and we look at all the vitamin deficiency in clinical findings, and sometimes they help us in making a differential diagnosis. This patient had magenta tongue, if you remember. Magenta tongue means riboflavin deficiency. The two signs are important. The tongue is magenta, pinkish tongue, suggests there is a riboflavin deficiency. And if the muscle is like what we call beefy red is a sign of B12 deficiency. So these points, if you look at in examination, these points help us in making it. So give us some clue that there is a vitamin deficiency. Now step 6. So if there are any of these, you will suggest this patient has a malabsorption. Now step 6. Because now there are a lot of disorders like celiac disease, tropical screw, Crohn's disease. So celiac disease and tropical screw are non-inflammatory. They will not have fever. They will not have joint pain generally. But if there's inflammatory disorders, there's like tuberculosis or Crohn's disease, they will have fever and joint pain. So if these are fever and joint pain, you will not think of tuberculosis. You will not think of celiac disease. So, and therefore, those disorders which are non-inflammatory in nature, tropical screw, celiac disease, GRD, parasites, and other uncommon disorders. And if there's a fever, then think of Crohn's disease, ulcerative colitis, tuberculosis. All right. So we will ask about fever and joint pain. If they're there, you will think of these kind of disorders. And again, I remind you again that we don't make a diagnosis just based on one parameter. We will combine all of them together and make a story about it. This girl had no features of fever and joint pain, so we call this girl as a non-inflammatory type of diarrhea. Furthermore, so and this is a conceptual that there may be any disease. If you talk of small intestine, large intestine, there could be only mucosal disease, like there are only ulcers in the mucosa. But lumen of intestine is intact. If lumen is also compromised, they will have a pain abdomen. So if somebody had a diarrhea and intestinal colic, you will think of there's a mucosal disease and there's a luminal disease. Right? At this point, again, help us in making diagnosis. So those who have a pain, intestinal colic, will think of tuberculosis, Crohn's disease, Whipple's disease, or chronic pancreatitis, which can lead to or there's no pain list, then mucosal disorders, tropical screw, celiac disease, and others. So somebody had a typical intestinal colic, you think of a luminal component. This girl had no pain. Now coming to one more step, you want to know if the mucosa ulcerated. There's a disease inside, mucosa ulcerated. If there's ulceration, there can be obvious bleeding. Maybe. If there's obvious bleeding, tells you this is a ulcerative disease. Like could be IBD, like could be ulcerative colitis, Crohn's disease, tuberculosis. There's ulceration in the small or large intestine. But if there's only mucosal disease and non-ulcerated, like celiac, tropical, they may not have blood. I'm not talking about occult blood, I'm talking about obvious blood. And this girl has no bleeding. So now we have got all this information and compile all of them together. Let's see where we are. So this girl has a young patient, recurrent diarrhea, small bowel type, because she has features of malabsorption. There are no inflammatory features, it was painless, there was no blood. So overall, you think what this patient has? She has a feature of malabsorption. It means what? It simply means there's a mucosal disease, and this is diffuse. Diffuse means almost whole of small intestine mucosa is affected, or large segment of mucosa is affected. If only small part of mucosa is affected, there will not be malabsorption. For malabsorption to occur, large part of small intestine should be affected. So this person has a typical mucosal disease, which is of large segment and has no prominent luminal compromise. So this patient, we can visualize this person has a small intestine type and diffuse mucosal disease. So how do we approach? Small bowel diarrhea could be with malabsorption and without malabsorption. With malabsorption, we have etiology like celiac disease, tropical sprue, parasites, immunodeficiency, IPSID, and others, Crohn's disease, autoimmune enteropathy. And without malabsorption, this could be biliary diarrhea or secretory diarrhea from small intestine, right? And if you go to large bowel type diarrhea, again you define it two. We call it functional disease or organic disease. Functional disease is IBS, diarrhea predominant type, or it could be functional diarrhea. And you make a diagnosis by Rome 3 or Rome 4 criteria. If it's organic disease, then this could be with blood, IBD, tuberculosis, tumors, or without blood, could be drugs or microscopic colitis. Right? So this how we will define small bowel type and large bowel type. And this is how you so once we have these information, as we discussed, you compile all of them together, what all this patient has, put them into this chart and think what this person has. So this person has a typical small bowel type diarrhea, had malabsorption. So my differential would be one of these, right? And I said in our country, the four most important causes of small bowel diarrhea with malabsorption are celiac disease, tropical sprue, parasitic disease, and Crohn's disease, right? So we are thinking of these three differential diagnoses in this individual patient. And if it was large bowel diarrhea, then we'll approach like a functional or organic and do appropriate investigations, right? So after this clinical compilation of information, we need to plan our investigation. And the planning investigation has a three basic principle. That they have a disease, so what is the effect of disease? You want to assess what is the effect of disease. Then you want to find out what is the structure or function of the organ from where this disease is appearing, and then you want to know etiology of the disease. Three things. So first thing is look at effect of absorption, effect of the diarrhea, then look at anemia, type of anemia, and other metabolic parameters. So since we are running short, so let me go rather fast. So this would be anemia. She had anemia of iron deficiency type, and she had poor iron stores, and she also had low B12. In addition, her LFT showed there's an increase in ALT/AST, so it means there's some amount of hepatitis going on, and she has a normal albumin, normal calcium. So then we go towards looking at how do I assess. So with this effect, we look at how to assess this person. So again, as I said, you want to look at mucosa, and you want to also look at the lumen of intestine. For mucosal functions, we want to assess the function of absorption. The two tests, D-Gylose test and fecal fat. They are not available everywhere, but these two tests are important while we work up patient with for malabsorption. You want to look at how the mucosa looks like when you do endoscopy, either upper GI or lower GI, depending upon what your clinical diagnosis. Here we are thinking of small intestinal disease, therefore we do upper GI endoscopy and see the folds of a small intestine, look at interfold difference, and we look at any other characteristics. If I think of large intestine, then we'll do a colonoscopy and look at mucosal appearance. Then we take biopsies and then describe. If I think of luminal disease also, we are thinking of there's a luminal compromise, and in that case we'll do CT intergraphy or MR intergraphy. So that couple of words about a test for malabsorption. The test is D-Gylose, which tells us that the mucosal functions are normal or not. So this is pentose sugar, and if this is less than 20% of ingested amount, then called abnormal D-Gylose, and tells you that there is a mucosal malabsorption. This person has a 0.7 gram of D-gallose expected was more than 1 gram. Therefore, we can say this patient has a mucosal malabsorption. Stool fat is not often done these days, but those who have mucosal malabsorption will have more fat in the stool, and we can estimate amount of fat in the stool by collecting 24-hour stool fat. And this test is not available, so I'm not going to available everywhere. It's available at our center, but I'm not going to go in depth of this test. So after that, we want to know the etiology, why this is happening. So for that, we do all the tests. As I said, the most important malabsorption are celiac disease. For that, you do serology for celiac disease. You do parasites, do examine stool for parasites, and also tell the lab that we want to look for parasites, and there are 5 parasites which leads to malabsorption. That is celiac, this Giardia, strongyloidosis, isospora, microsporidia, and cryptosporidium. And all this cannot be seen routine stain. Therefore, request lab to do special stains to find out these parasites. For immunodeficiency, ask for serum immunoglobulin levels that of IgA type, IgG type, and IgM type. Assess that. There are few patients coming with chronic diarrhea with malabsorption have immunodeficiency. So one should pick up these. Do HIV and look if HIV. If you're thinking of bacterial overgrowth, then do glucose hydrogen breath test likewise. But more important, so as I said, you look at stool examination. Celiac serology is done. You have a 3 serology, that's a TTG, which is the most common test done to look for celiac disease, and is very high sensitivity and specificity. One can also do anti-indomitable antibody, either TTG or EMA or both. They are good screening tests and they have a lot of diagnostic value. So this lady we talked about, young girl, stool showed cyst of Giardia, and her TTG was strongly positive, more than 10 folds than cutoff, and her anti-indomitable antibody was also positive. So it means she had a celiac disease. So what? So after that, we want to look at histology. What is the disease in the small intestine? For that, you want to look at histology of small intestine, and for that to get histology, you have to do upper GI endoscopy. And in upper GI endoscopy, can see multiple findings. So these are normal. So these are normal folds in small intestine. So these folds are normal in nature. So you can have atrophic folds. The folds are atrophic. You can have a more atrophy of the folds. As you see, the folds are not seen here. The folds are like these folds are every centimeter, so there are 3 folds, and each fold is about 3 millimeter in diameter. Here there is no folds. So this is called typical atrophic folds. You can look at scalloping of folds. This is classically seen in patients with celiac disease. You can have these nodularity in the small intestine, and these are nodular lymphoid aplasia. Anybody has chronic diarrhea and you do upper GI endoscopy, you find these findings. Always think of a nodular lymphoid aplasia, and most of these time they have a chronic variable immune deficiency. In immunodeficiency, you find this kind of finding. At the same time, you can find these are white spots over the mucosa, and that's typical of lymphanectasia. There's a lymphatic, they are dilated lymphatics. You see these white spots, they are dilated lymphatics. So this gives you some of the differential diagnosis on endoscopy. So you will take biopsy, but even if the mucosa is normal, you must take biopsy. And in biopsy, again, it could be diagnostic. Most of the time, biopsy is not diagnostic. It gives some clue, but certain situation gives a confirmed diagnosis. Like in Whipple's disease, you find a lot of past positive macrophages in the lamina propria, which is characteristic of Whipple's disease. You find in A-beta lipoproteinemia, I'm not going to go into depth that. Lymphoma, you find more of monomorphic cells. Parasite, you'll find parasites. But more important is most of the time you find there's a villus atrophy. So this is a normal mucosa, this is a villi, this is a crypt. So in those who have malabsorption, they have a atrophy of villi. So normal should be like this, but there's no villus there. There's no villus and there's only crypt seen. So this is typical of malabsorption. It's called villus atrophy. I'll skip a couple of slides and and in want of time. So biopsy will tell us that most of the time that you look at crypt villus architecture, and just that you say the amount of villus atrophy the patient has. You look at parasites, look at lymphatic dilatation, which we diagnose with lymphangiectasia. If there are vacuoles in enterocytes, it's called A-beta-lacproteinemia. And if there are a lot of monomorphic lymphocytes in the biopsy, then it's an IPSET. If you are thinking of a large intestine and do colonoscopy, then do a colonoscopic biopsy. So coming to index patient, this patient had this kind of feature. She had a scalloping of fold on a biopsy. He has almost no villus. They all are crypts. So there's a severe villus abnormality. So this person has, so the next question comes, do I do, in this person, do I do luminal imaging? Do I do a CT or MRI? There's no need. Unless the patient has pain abdomen, you will not do CT or MRI in patients with chronic diarrhea. And 2 points I want to highlight. If there's no pain, then there's no point doing CT or MRI because they will not yield you any new information. Point number 1. Even if you want to do a CT or MRI, don't do a CT or MRI. Please do CT angiography. Because for CT, you do only CT scan, you don't see lumen of small intestine. And here you want to look at lumen of small intestine, those who have pain abdomen and diarrhea. Therefore, always advise CT angiography or MR angiography, not CECT. CECT is a not good test for luminal imaging. You want to look at lumen, please do CT angiography. And it's not difficult at all. It can be done anybody who has a MDCT facility available. Only thing is that while doing a CT scan, ask the person to drink 2 liters of either mannitol or polyethylene glycol. And your radiologist can easily do it, right? Please request your radiologist that I don't want CECT, I want CT angiography. And this is going to change the information you give more information than doing only a CCT. And therefore, it should not be done in all patients. Only those patients who have luminal symptom in patients with chronic diarrhea will do CT or MR. So coming back to this patient had typical mucosal malabsorption. She had diarrhea, anemia, short stature. She has positive serology and she has a severe villus abnormality. So her diagnosis was celiac disease. So all those patients with celiac disease, will treat them with gluten-free diet. And again, I want to make one point out here that just writing a prescription that do not take wheat is not end to it. Because unless the patient go to a dietitian and consult properly about a wheat-free diet or gluten-free diet, patient can never comply. And this is one of the most important things which the world has learned, that all patients with celiac disease must go to a dietitian for a complete counseling about the disease and the diet. None of us, although my interest is celiac disease, but again, I can't advise my patients I can't counsel completely about a gluten-free diet because I do not have enough information about all the food which is available at home or in the market and which are gluten-free. Therefore, all these patients must be referred to a dietitian. If that is not available, then probably we should try and read more about a gluten-free diet and learn ourselves and prescribe appropriately. I think if time will not permit, I will stop here. Maybe I just take one algorithm here that if you think of malabsorption, then we go into this algorithmic manner and look at all the etiology of disease. If there's no etiology found, then we call tropical sprue, because tropical sprue is a disease of diagnosis exclusion. Tropical sprue, if you say this patient has a chronic diarrhea with malabsorption, our diagnosis is celiac disease, tropical sprue, parasites, Crohn's disease, right? So we look at all this etiology, right? And if we find no etiology, then call tropical sprue. And that time you give antibiotics for 6 months. You give doxycycline 100 grams twice a day for 3 to 6 months and look for response. And response in terms of clinical improvement, and also do biopsy after 6 months to show reversal of changes in the biopsy. Only then you can say tropical sprue. Just to take 2 short cases, this patient is 36 years female. came to us chronic diarrhea for the last 7 years, 3 to 6 stools per day, high frequency, but small volume. Please see, high frequency, 3 to 6 per day, small volume, no nocturnal. Typical large bowel type, right? She also has abdominal discomfort, get relief with passage of stool. The pain in abdomen gets better after passage of stool. Feeling of fullness, bloating, normal appetite, no weight loss, but she also has generalized weakness. So what does it mean? This is a chronic large bowel type diarrhea. No malabsorption, no pain, no inflammatory features. This is functional disease. So this is a functional diarrhea, right? So how do we approach this person? So I just say this is functional diarrhea. I don't need a colonoscopy in this individual. I simply treat like giving her antidiarrheal treatment. Or maybe give a course of antibiotic if you're thinking of small intestinal bacterial overgrowth, because almost 30 to 40% of patients who present as functional diarrhea have a small intestinal bacterial overgrowth. Therefore, you give a course of antibiotic and give it antidiarrheal drug. And you will not need any kind of colonoscopy in these patients. Take one more example. 40 years female, she had diarrhea, or 40 years male, chronic diarrhea, and with bleeding for 5 years. So she has a more frequency of diarrhea, but diarrhea stool is mixed with blood for 5 years, small volume, and he also has a recurrent intestinal colic with obstructive features. So he had along with diarrhea, along with the bloody diarrhea, he also had a recurrent intestinal colic with obstructive features. It means what? There's also luminal involvement. So there's a bleeding, means there's a mucosal disease. There's also a luminal component because there's a pain abdomen. There's a weight loss. There's occasional fever and occasional joint pain. What all these suggest? This patient has a chronic diarrhea, functional organic. This is organic nature because there's a blood in the stool. There's a small large intestine, high frequency. Okay, high frequency and blood. So this is a large intestine type diarrhea. It's painful, luminal disease, had inflammatory features, have blood. So what does this mean? Chronic diarrhea, which is organic in nature, large bowel type, painful, inflammatory features, bleeding. All this mean there's ulcerative disease of intestine, of large intestine, and also has luminal component. It means there is also some amount of stricture in the GI tract. What the diagnosis? Is it comes here, organic disease with blood, IBD, tuberculosis. So these two different diagnoses look for in this individual. And in this person, to look at these, you do a colonoscopy, and once you do colonoscopy, always take multiple biopsy from all the segment of intestine. And this point is very important. Many times we don't do enough biopsy, but in patients with IBD or tuberculosis, always do multifocal biopsy. There's a good data from CMC Valor that more you take biopsy, more diagnosis you achieve. So take biopsy from every segment of your intestine and send the biopsy to pathologist for examination. And since it is luminal compromise, therefore we'll also do luminal imaging. What luminal imaging? Not CECT. It has to be CT interrography. And this person will have either IBD or tuberculosis. So with this, I come to conclusion that chronic diarrhea is an important disease. We often see in our clinical practice. The causes are multiple, are 100 in cause. But if you approach them systematically, all through bedside clinical approach, we will be able to make a good diagnosis clinically, and we'll be able to choose investigations most appropriately. And therefore, we can target our investigation depending upon is it a small intestine or large intestine and make a diagnosis. With this, I stop here and thank you everyone for your very kind listening to this late evening talk. Thank you very much.
Thank you, sir, for your presentation. It was very lucid, and I'm sure all the audiences might have got very nice information. So I request Dr. Gautam, Dr. Venkat, and Dr. Nakul to please share your experience and then proceed to the chat box where audiences have asked few questions.
Sure. Thank you, Dr. Makaria. It was a very lucid and a very, I should say, very simplified presentation of a very, very complex topic. I had one question. So we have a lot of patients who have sometimes this, even in your patient, you mentioned that this patient had giardia cysts. So what do you do for this asymptomatic cyst passers versus a patient who has diarrhea with cysts of giardia?
So
So do you treat
giardia
it?
should, sorry, giardia should always be treated. Always be treated. Giardia. Giardia,
Cysts?
either you pass cyst or trophozoites, giardia must be treated.
Okay.
Even if you find giardia at any point in time, you must be treated.
Even in asymptomatic
Yes, yes.
passers.
Now,
Okay.
unlike amoeba, most of the amoeba are non-pathogenic in nature.
Correct.
Therefore, you don't treat them. But giardia, every time you find giardia of whatever patient, you think patient with a, say, cancer or whatever, you do the stool examination and find giardia, always treat that.
Okay. Thank you, sir. Gautam, Nakul, I think if you have any
Many
questions.
many patients have with IBS like symptoms. They are diagnosed as later celiac disease because many times symptoms they overlap. But in your talk, you mentioned that if the patient is having functional diarrhea, don't go for colonoscopy or don't go for any other imaging. So what is your take on that? Because many times it happens that patient has celiac disease or IBD and still they have functional all Rome criteria which they fulfill.
I think Dr. Yogesh, you made a very important point, and I had to go in passing because the time was passing by. But again, your point is very, very right. That before we say functional diarrhea, there are certain disorders like small intestinal bacterial overgrowth can have a picture like functional diarrhea. Giardia can have look like functional diarrhea. Even celiac disease can have look like functional diarrhea. And I agree that before leveling functional diarrhea, it should cross our mind. And if there are other features, should do appropriate investigation. Now we know that IBS diagnosis now earlier it was a best possible diagnosis. You don't have anything to say IBS. But IBS patients do have lactose intolerance, they have lactose intolerance, they're treatable disorders. About 2 to 3% of IBS patients do have a celiac disease. If you look at 100 patients with IBS, and if you have IBS diarrhea type or mixed type, almost 5 to 6 of 100 will have celiac disease. So now there are now guidelines that those who have IBS functional diarrhea or functional or mixed type of diarrhea, you should look for celiac disease. I agree with you. I missed that point. Yes.
Sir, one question, sir. Many times a patient and relatives are also asking whether to drink milk during this diarrhea period or everything. So, what is your opinion, sir? In specific disease or without disease, about opinion about milk, sir?
I think milk are a bit. I want to highlight 2 points. That for vegetarian, milk is very important source of calcium, right? For non-vegetarian, they get calcium from different sources. So stopping milk is not a great idea, right? If somebody has a milk intolerance, that you take milk and the frequency or volume stool increases, then one can think this is lactose intolerance. Even though the test is not available, one can say this lactose intolerance. Ask the person to take, rather than taking a full cup of milk, take half a cup of milk at one time. They take twice a day. So milk intolerance is always relative. Anybody take 2 glasses of milk, most people will have diarrhea. Because none of us will able to absorb that amount of lactose or digest lactose. But again, it's always relative. Therefore, ask the person to take milk twice, and the amount of milk may not be large at one time. So maybe
Yeah.
half a glass of milk, just for a vegetarian, because you stop milk and you don't have calcium.
Yes.
Now we have lots of questions coming in from the audience now. So a very relevant question is one is about the role of isabgol in functional bowel disease, functional diarrhea. So
You use bulk in those patients who have a bulk laxative, like a subgol is a bulk laxative. This is a fiber you use in constipation type because you want to increase the volume of stool, right? But look at this is a point which is important that in our country all of us take a lot of vegetable, a lot of fruits, and therefore our fiber intake is already high. So giving more fiber may not do any good. But there's some personal experiences of a lot of physicians that those who have functional diarrhea, you give little fiber, so stool consistency decreases, right? And but frequency will not change. So if they have a functional diarrhea, the frequency will not change, but the amount of stool which was say 50 gram or 100 gram becomes 150 gram because you're taking more fibers, which are undigested. But they don't help into control of symptoms. The only thing is stool volume becomes slightly more.
A question has come that a lot of functional diarrhea patients have a moderate quantity of mucus in stool, and they are very concerned about that mucus. So, does it make any difference or change in your management? Presence of
Not at all. What I believe, the mucus is probably more goblet cells in the histology, and this is a non-pathological. It doesn't worry. Mucus, I think I can't understand mucus has any consequence. Like they pass stool, and some mucus doesn't worry me at all. So I'm not concerned about mucus in the stool, and I always try and tell all our patients that mucus, please don't worry. Little old mucus passes. I don't think we should do anything about that.
One of our gastroenterology colleagues has asked that if there is a Dr. Jigar Patel from Ahmedabad, he's asked that if there is a patient who has a normal IgA level and with a negative IgA TTG, so does that essentially rule out celiac disease?
Likely yes. Likely yes, because the TTG is a positive 95% times.
Yeah, so IgA TTG. So
IgA TTG.
yeah,
So, but the 2 points I want to make that TTG kits are supplied by many vendors, right? And there is a difference in the performance of each kit. And we have found that in about 5% of patients, which is a high positive TTG by one kit, tenfold TTG by one kit is negative by other kit. So little difference, somebody has a TTG of 20 and 25 could be falsely positive or negative. But even at a high titer, tenfold high by one kit is negative by other kit. Same time, same blood sample. So there is a variation in performance of different kit. If your suspect is high, maybe repeat once more before you say no celiac disease.
another question is how long to give rifaximin. So how long can we give in a patient who has kind of the question asked is small bowel and large bowel diarrhea, but I presume it must be about IBS. So how long can we give
10
rifaximin?
to 14 days. 10 to 14 days.
My personal one of few of my patients, they say that sir, is there any harm in continuing it, and they somehow tend to continue it for a long time. So I mean, I said, see, the cost is the only problem because rifaximin per se is a costly molecule, but they say that we don't mind the cost, we'll continue it. So is there any harm? Of course, we all know that it's a non-absorbable, so no cost.
It's not about if you topical sprue, certainly you give longer period.
Yeah.
But what happens? All these drugs have a lot of placebo effect, so they become dependent on that, and then they'll keep taking. So they keep popping. What happens with all of us? So and the typical story of our country that somebody had diarrhea, even for one day, they go to a medicine shop and take Norfolk TZ and they take pop up 2 pills and they're all fine. Diarrhea was to stop anyway after this infected diarrhea is stop in 2 or 3 days time, but everyone in our country will take antibiotic for even one day of diarrhea. Therefore, what they will do every time they have diarrhea, they take rifaximin rather than they change from norfloxacin to rifaximin. Probably may not be indicated again, but you're right that they will always have recurrence. So you treat now, the symptom gets better, but recur again, then you probably use then. But chronic use probably, except for tropical sprue, may be avoided.
Fine. There is a question which is not directly related to chronic diarrhea, but something related to tofacitinib and its prothrombotic side effect in a post-COVID steroid refractory UC. A very complex.
Say it again. I didn't get that question.
This is Dr. Devender Singh from Bilaspur who has asked about keeping in mind the prothrombotic side effect of tofacitinib. How can we use it in a post-COVID refractory UC patient?
Post-COVID means the patient has
Person
COVID.
has recovered from COVID, and he might have taken tofacitinib for the treatment of COVID, and he in this patient of steroid refractory UC, and I mean the prothrombotic side effect. So steroid, we all know that, I mean, IBD is a prothrombotic state. So what is the interaction of giving tofacitinib in a patient who has steroid refractory UC? Would it lead to a procoagulant side effect?
I'll reserve my answer on this because I have to really understand and read more about
Yeah,
it.
yeah. I mean, the question is also a little vague, so I was not able to understand it completely. Uh, Microscopic colitis, what is the approach?
The first thing is to detect. Treating is not a problem, but detecting is very important. And how do I detect it? Because somebody thinking of a functional diarrhea, you take biopsy from the large intestine, both either rectum and also mostly from left side or right side. But if you're not doing even right side colonoscopy, you're doing only sigmoidoscopy, then take biopsy. But send this biopsy pathologist. What the report comes? Non-specific colitis, majority of time. Because pathologists never look for microscopic, because it's not a routine diagnosis which come to their mind, seen by residents or even by senior pathologists. They will never report like microscopic. But if you write in the form before as a request that we are thinking as a differential diagnosis, so we are giving a clue, please look for microcolitis, then they will count IELs per high power field or per 100 colonocytes. They will count they will do a special stain for look at the basement membrane thickening, right? Look at collagen band. Only then they will report. The first thing that once you suspect anybody who has a functional diarrhea, as Dr. Yoga also said, look for do biopsy and confirm there's no microscopic, and request pathologist that please look for microcolitis in this individual. Once it comes, the first step is give antidiarrheal. You can use loperamide or even diphenoxylate for control of frequency. If they don't work, then there are data now, there are guidelines that you treat these patients by using budesonide for 3 months. And majority of patients will respond in symptoms, then you stop it. If they have recurrent symptom, then again you treat them with budesonide for 3 months and maintain them on azathioprine for a long time.
There is a question of MMF diarrhea, mycophenolate diarrhea, how to manage or reintroduce.
So again, this is again very important. Now we have made a guidelines, which is called ISSA-specific guidelines on uh, on treating diarrhea of those who have immuno compromised and also those who have post-transplant recipient patients. So once you have mycophenolate, before that there is steps, 3 or 4 steps that look out common causes. And if you think mycophenolate is the cause, then two things to decrease the dose, make the dose half, and see diarrhea subsides. If it does not, then you have to replace the alternative drug. But before saying mycophenolate, we have to follow 3 steps, looking at the infective cause of diarrhea, looking at mucosal cause of diarrhea, and then only come to drug-induced. But drug-induced diarrhea is very important in this setting. Mycophenolate is very important. 2 things to do. If you're confirmed or you want to thinking very serious about drug-induced, half the dose first, and if no response, then full dose. I mean, you stop the drug. And
Can
say,
we read? So when to reintroduce?
uh, I'm not sure about that. I don't have personal experience in that. So I think after stopping treatment, and maybe what I'll do after 4 to 6 weeks, reintroduce and look at if they have recurrence of diarrhea. If they have recurrence, then probably I'll go for long term, not using the drug. Or if there's a no recurrence, then I'll continue this drug. But I'll wait for at least 4 weeks.
Is there a way to manage intestinal lymphangiectasia? Is the question.
Very important. If there's a lymphatic dilatation, so it means they're losing lymph in the gut. So they will have protein losing enteropathy. First thing, how do I diagnose protein losing enteropathy? And simple. is to look at the serum protein. We always have serum protein data available. If the whole protein is low, protein is 5 to 8 grams, you find whole protein is 4 grams. Think of a protein-rich enteropathy in setting of chronic diarrhea, or otherwise also. Because if both albumin is low and globulin is low, protein-rich enteropathy is one important difference. And we'll think of lymphangiectasia in this individual. And the treatment of that will be only dietary. That you avoid, ask the person to take MCT diet, means ask them not to take the regular oil, which is palm oil or other oil. They should take coconut oil for food cooking. Coconut oil is more of a MCT. The MCT will be absorbed directly from the enterocyte and they will not go to lymph. Therefore, lymph will not rupture. So treatment of lymphangiectasia is give dietary modification and asking them to use oil which has a medium chain triglycerides, that is a coconut oil. And there are other things are also available, but they must not use regular oil for the treatment. So, and certainly you give them more protein, right? And look for the cause.
Question is that how long to continue gluten-free diet? Of course, it is lifelong in celiac disease.
It has to be, if diagnosed as celiac disease, it has to be lifelong at this point of time. Although number of has to be lifelong and it has to be complete. And again, to emphasize a point that there are some patients or physicians, symptom improve, everything gets better. They go to doctor again, and doctor starts, up, theek ho gaye, ab start your normal diet. Now, you do more harm. No question about it. This is almost certain that all patients with celiac disease is a lifelong gluten sensitive. Therefore, they have to follow lifelong gluten-free diet. There's no doubt about it. The number of drugs which are going to come, but again, they are not going to replace gluten-free diet. The drugs will be add-on drugs, but the diet has to be gluten-free at this point of time.
Sir, I have a question. When we screen the siblings of celiac disease, then of course we just do a serology. So there are some who want to know whether anything more can be done. So do we do HLA, DR2 and DQ?
No, it's no need, no need to do. If because 80% or 85% of family members will be DQ2, DQ8 positive, or DQ2 or DQ8. So normal population 30% of them, all of us, 7 of us, 2 or 3 will be DQ2, DQ8 positive. So 30% of normal people will be DQ2, DQ8 positive. Celiac 90%. Our data shows less. Indians have less, but say 90%. But family members 80%. So almost everyone. So DQ2, DQ8 will not be help anyway. TTG is good enough. And certainly one can repeat TTG after 1 year or 5 years, but TTG is the test for screening. And almost 10% of family members, if you have one celiac, then maybe his brother or sister may have celiac disease. So all siblings, parents, and son and daughter must be investigated for celiac disease.
So it was very informative session, sir. Lot of questions were there, and you have given wonderful answer. So I thanks everyone, sir. Thanks to you also, sir. You have given so much time to this session and discussed so much detail about chronic diarrhea. Thanks, our chairperson, Dr. Venkat sir, and Dr. Now I ask Dr. Yogesh, just please say 2 or 3 words.
Thank you, sir. Very much honor from our Association of Physicians of Ahmedabad. And it was I think physicians, we always gastroenterologists listen to you. Maybe physicians of Delhi and North may be listening to you. But this might be the first time when physicians of our region has listened to you. So it's an honor for all of us. And thank you so much for giving us so much detailed information in short time. Thank you, sir. Thank you so much.
Thank you so very much. It was class. Good night, everyone.
Good night.
Good night, sir.
Good night, sir.